Okay, so the elephant in the room or the red flag are actually a number of syndromes, not a specific diagnosis. So we'll see how quickly you guys get on board with what I'm having to say. What we are talking about today is very common and very well known and very much in the forefront of our mind. And as providers, we have convinced ourselves that we address these things every single day. Awareness is consistently rated as high. However, we have a number of research studies that says our clinical practice and our screening and diagnoses for this elephant. These are some pretty challenging statements here. Non-existent and suboptimal. Nobody wants to be suboptimal in their clinical practice. And our screenings and ability to identify these things says far from fully integrated. So that should be a little bit of a wake-up call. Despite the evidence, which goes back literally 30 years in the journals and the medical research, adequate clinical screening is dramatically lacking. So there's something going on that we are missing and not identifying that is actually quite important. I'm going to give you maybe 3 or 4 case studies today to help highlight this. So this first case study, we have an older gentleman with multiple falls and a risk for fractures. He is appropriately referred to physiotherapy. The physiotherapist does an appropriate evaluation and gives an exercise program and gives an assistive device and sees the patient back for additional training. The physiotherapist does all of the good things and says low risk for falls. Here's my concern. We have a chart that says multiple falls and we have a physio that says low risk for falls. Somebody's missing something. So is the chart wrong or is the therapist wrong? Don't answer that. Don't answer that. So this gentleman gets the formal workup, he gets all the exercises, he gets all the instruction, yet he is continuing to have multiple falls despite intervention. What went wrong? When he came to see me in my falls specialty clinic, these are some of the exams that I do. And maybe some of these were included with the other physiotherapist, but we'll see. This patient was definitely orthostatic. His ability to stand was 75% good, but that's still a 25% deficit. His gait speed was slightly slow. And his timed up and go, I would say, is acceptable, maybe not normal. But falls risks are stated to be slower than 14 seconds. And this guy was faster than that. So why is he still falling down? As we look a little deeper, adding a cognitive task to his timed up and go, he was 3 times slower. Doing tire jobs, he was 33% slow, but with a cognitive task, he completely failed. Doing the multi-directional 4-square test, he completely failed that. This gentleman was not falling because he couldn't walk. He wasn't falling because he couldn't step over a box or stand with head turns. He was falling because he would go to the market and get lost and wander the neighborhood for 2 hours and then have to call EMS after he fell down in the park and couldn't remember his name. So standard therapy does not assess cognition often enough because we maybe think it's the occupational therapy job, or it's the neuropsychology job, or it's the geri-psych job, and it's somehow not our job to do that. So we tend to overlook these concerns. Case study number 2, the physician says, please see my patient for back pain from a compression fracture. I am perhaps wrongly assuming that this compression fracture is because of a fall. Why is the guy falling down? The doctor says he's older, it happens, just give him a TENS unit to help his back pain. Very diagnostically focused. has back pain, has compression fracture, needs therapy. This is what we do. This is what physiotherapists are good at. But the problem is that he drinks way too much, and he has neuropathy, and he has myelopathy, and he's orthostatic. These, don't think a TENS unit or a Pilates exercise are going to help these issues. These are the issues underlying his back pain and his difficulties and his falls. And I don't think McKinsey is the answer for these problems. This directed more towards the physios than the physicians, but it is imperative that all, let me say, providers should be able to implement quick and appropriate screenings to identify patients who are at risk. Again, some of these research studies go back more than 10 years. This is a lot of evidence that we can identify patients early on. There were a couple of talks yesterday about lower back pain, and we just had the case study of Bob with his compression fractures, right? Low back pain was cited as being the leading cause of disability, right? Is low back pain the most important undertaking in the 21st century? Maybe, maybe not. I don't know. I think that they're not necessarily talking about lower back pain. Identifying function limiting and predictably progressive conditions can reduce the severity. If we can identify risks for back pain early, yes, we could maybe reduce the severity. But again, I'm not sure that that is specifically what we are talking about as this global health crisis. Case study number 3, Adelaide, 62 years old, was seen by physio for right shoulder concern. That physio did a phenomenal job. Let me tell you, that was probably the best cervical shoulder rotator cuff evaluation I have ever seen in my life. It was amazing. I couldn't do a rotator cuff eval that well, but the patient comes back to me for balance concerns because I'm in the Falls specialty clinic. And so I asked the patient, hey, how long have you been having balancing problems? She says, well, a couple of years. So her balance problems predate her shoulder therapy, bearing that in mind. So I asked, what did that therapist say about your balance concern? There's your answer. We didn't talk about that. They're fixing my shoulder. Very diagnostically focused care, not looking at the patient. This article is nearly 10 years old now. This was a game changer for me. This completely altered my practice. This was mind-blowing for me. And this information, this was a multinational study from 11 different countries. And this was amazing. Let me wrap up the story about Adelaide before I get to what the predictors are. When I saw Adelaide for balance concerns, she had a right-sided limp when she came in. She underused her right leg for sit to stand. When she did tandem stand, she tipped over to the right consistently. Either foot, it was always to the right. I'm thinking, if it's your right shoulder, maybe that explains your weakness, but what does that have to do with your right leg? Suddenly I'm thinking TIA or CVA or something. So I sent Adelaide for a CT scan, and it was not a stroke. It was a glioblastoma. So not a great outcome, but again, the best shoulder therapist in the world isn't going to identify those kinds of things. Functionally focused examinations, even very brief ones, can be done in any clinic to identify early predictors. Any idea, before I pop Goldman up here, what some of the predictors of mortality are?
Efficient locomotor.
Inefficient locomotor.
Yes.
Any other ideas? Falls. Any other ideas? Fractures.
All locomotive.
Y'all are right there. All of those things are locomotor, correct? But y'all are being way too thoughtful on these things. There is strong merit in identifying these things regardless of our care. And we should consider using these in healthy populations. Josh and I were chatting 2 days ago. Who is going to pay for us to do an intervention on a healthy patient? If we prevent the fall from happening, who's going to pay for the fall? There isn't necessarily good reinforcement to do preemptive, preventive, early screening, but that's the way that we intervene earlier. Of the 25 factors most associated with mortality, several of these could be assessed very quickly in clinic. Sit to stand, gait speed, hemoglobin A1C, inflammatory markers. These are roughly half of the list that Goldman established of the 25 predictors of survivability or mortality.
Can add liver function.
Liver function tests are newer. Again, this was 2016, and the liver function test, the metabolic syndrome, is a newer phenomenon. Although inflammatory markers can cover some of the liver function. So here's Bob and his back pain. The doctor said, just give him a TENS unit. He doesn't exercise. He has high BMI. His A1C was 6.8. And he sits at home and feels depressed. What Bob needs is not a McKinsey exercise program. He needs a referral to psychology and social work and an exercise program, not a TENS unit, not a yoga program. Physios should consider using performance measures on adult populations, like the gait speed and the sit to stand and those types of things. Adelaide, we talked about this already. And the glioblastoma was showing up by a globalized right-sided weakness. No reflex losses, no hypertonicity, no wasting away, no atrophy, because it was very early on. But the shoulder therapy didn't pick up on that. So these syndromes, these symptoms, these red flags leading to, have we identified the elephant in the room? Falls, frailty, failure to thrive, poor quality of life, premature mortality. These are actually highly prevalent in societies. They are multifactorial and complex, is why we miss them. We're not looking for complex things. We're looking for rarely seen things or things that are specific to our expertise. Associated with substantial mortality, very poor. Glioblastoma does not have a great outcome, I'll tell you that. High expenditures as we are caring for people. Decade after decade after decade, they're in long-term care. They don't get to rehab soon enough, like Lisa was talking about this morning. So there's a delay in care, and then they discharge home. That's family burden. It's taxing on staff and resources. These patients are often over-medicated because they have multiple things going on. So they have pain, let's give them a pain med. They have cardiac problems, let's give them a cardiac med. Now they're orthostatic, let's give them that. Then they get depressed because they can't be active, so we'll give them an antidepressant and refer them to another provider. So these are very difficult cases, reliant on family support. This is Bob. He goes to the store and then has to call an ambulance because he falls down and can't get home, right? So this is what has been identified as the population ages. This is the impending global health crisis, is older people living without a quality of life, living but not functioning, living but taxing on the healthcare system. So what do we do about this? Continue on, right? I propose that we need to be more preemptive and more proactive. And we could assess some of these markers in 40-year-olds who aren't falling down and who aren't in the wheelchair and who don't need the rehab. 72 was your average age? 76. What if we start 20 years earlier in the mid-50s prescribing things to prevent some of these problems going on?
Here we go. Okay, for 40s for female, because.
And that's why the talk was called the
Yeah.
40 to 65-year-olds, yes.
It's not postmenopausal, it's pre-menopausal.
Gait speed, sit to stand, and static balance have been suggested as preclinical tests that could be done on middle-aged patients. This is primary care. This could happen in primary care. In my Monday through Friday work, I am in a primary care clinic. Some of you are not primary care providers, but these tests could be done preemptively early on. This was 2 different articles stating basically the exact same thing. There was a book, it's now in its like 4th or 5th iteration. It was very amusing to me. It's rude, it's written very crude and in your face. But what if I don't want to get sick and go to the doctor? What if I don't want to break a leg? Medical practices aren't set up to be preemptive. Doctors are often not trained for this, and insurance certainly isn't willing to pay for something that hasn't happened yet. Something like waking up dead. Nobody wants that. So, Lisa talked about gait speed. She had a cool slide up this morning, which I actually took out of this presentation last month. So I'm glad you had it. Thank you for showing the little bar graph of gait speed and function. However, gait speed shows high sensitivity and excellent predictive ability for what? Future disability. So I do a reflex test. What does that show? A reflex loss that has already happened, right? I do a strength test. What does that show? Strength that is already lacking. I do a liver function test. What does that show? A liver that's already not working well. Declines in gait speed can preemptively identify those problems years or even decades before. Obviously, it's not specific to liver function, for example, but it is predictive of things like cognitive decline. Predictive of health status for veterans. Predictive of mortality and cognitive. Predictive, this is preemptive before diagnosis. Functional loss or functional ability, balance and confidence, future health status, rehab potential, discharge location. That's why I said that this morning. Mortality, and a great article right out of here in the UK, how fast does the Grim Reaper walk? Any guesses how fast mortality speed is? Very, very, 0.05, he says, 0.47, yeah. So I think of it like a percentage, 47%, 0.47 meters per second. Their 5-year mortality, well, I think the quote was, no one slower than 5 survived the 5 years, so something like that. All right. This is 6 different articles that I reviewed to kind of get a summary of this, specifically for physios, but I found this to be interesting. Oddly, physios lacked knowledge about exercise guidelines. What? We do exercise every day. How can we lack knowledge about exercise guidelines? That's what they report, all right? Lacked counseling skills. I can believe that. It was too much to ask of patients. We've already given Adelaide shoulder exercises. I can't expect her to do balance exercises besides, right? The reason her shoulder hurts is why? Because she always falls to the right side. So she always hits her right shoulder. Oh, we talked about this yesterday in silos of care. Patients come in with multiple diagnoses, and how much time do we have? Not enough is the short answer. 2 different articles noticed that we are focused on acute treatment, like the back pain, give him Pilates, don't assess his falls. And 2 different articles noticed that there was a lack of financial priority to emphasize exercise. There's actually, while there are guidelines, there isn't really a framework for how to teach exercise promotion. Timed up and go. That was one of the ones that the 78-year-old guy who had already seen physio, his timed up and go wasn't terrible, but timed up and go is associated with mortality. Gait speed and timed up and go together also associated with mortality, depending on who you read, because someone else says static balance and timed up and go. Someone else says alternate stepping and timed up and go. Someone else says sit to stand. Okay, everybody loves the timed up and go. Literally, it takes 20 seconds. Any provider could do that in clinic. Actually, if it takes you 20 seconds, it's too slow. And then in the case of this patient where he was having multiple falls, timed up and go with a cognitive overlay, that's where he really started unraveling 3 times slower doing that. So just a couple of quick articles up here if you want to look those up in your free time, or if you have insomnia, great reads for that right there. And there's actually more specific to Parkinson's and specific to stroke and gender differences in cognitive locomotion. A quick performance screen. I'm not going to go over all of these, but these are just some ideas for a really quick functional thing that could be implemented in clinics. It's also kind of fun to try these at home. The virtual guys are going to miss this if I try and demonstrate, but I don't know. Should I? Should I not? But you can try this at home, right? Putting on a shoe and sock while you stand on one foot, right? Do you have the balance and flexibility to be able to do that?
It's draining sometimes.
It is, exactly. Being able to get all the way down on both knees and back up and do that with both of your legs. That's a good, easy one you can do, right? For the cognitive, doing a 5 times tug shuttle while they tell a sequential story. Tell me about getting ready this morning. What did you have for breakfast while they're doing the timed up and go 5 times? And then this is one that I like really quick. We have the time, let's do it. Scoot your chairs back from the tables. No cheating, you gotta participate. This is a physio presentation. You guys got to do stuff. So back from the tables. What I want you to do is fold your arms and put your feet together. Feet together, and then this is brave. Eyes closed. And you're going to lean to one side as far as you can without tipping over. Keep your eyes closed. Just lean back to the middle. Pause in the middle. Keep your eyes closed. I'm looking for overcorrection. Lean to the other side. Don't tip over. Back to the middle. Good. Keep your eyes closed. Keep your feet together and stand up. Keep your eyes closed. Keep them closed. Keep them closed. Checking balancing. Monitoring that. Keep your eyes closed. This doesn't have to be big. March in place. March, march, march. Step, step, step. I know the table's in the way. You're going to hit your knees. It's not completely accurate, but we're getting the idea here. March in place, 20 seconds. Pause. Open your eyes. Are you in the same position as you were? Because if you have drifted or moved, that is a vestibular hypofunction. Next, eyes open, arms folded, tandem stand, 1 foot right in front of the other one. Stand, balance, tandem. If you're only going to do one balance test, tandem is the one to do. Dr. Ali is brave. He's doing tandem, eyes closed. I didn't ask for that. He wants extra credit. I'll have patients do that on both sides. So we can do this in 90 seconds. We have assessed you can have a seat, proprioception and balance and vestibular and sit to stand and assess for neuropathy by standing with your eyes closed. So we have hit 5 little things in 90 seconds, and it's a little bit of everything. It's a quick, easy screen that providers could do in clinic. So in conclusion, and see, I'm early so we can have questions. This was mentioned also by Lisa this morning. Consider having gait speed as a functional sign. That was first suggested in a white paper by Fritz 2 years ago. Ask about mobility or balance concerns in anyone after 50, or Dr. Ali says, after 40. I agree.
Especially for premenopausal.
Correct.
Yes.
And that's why the actual title of this is Red Flags in 40 to 65-year-olds. If you wait until after all this changes, again, you're not being preempted. And why couldn't you ask it in age 30? Why not? Why?
There is family
And
history. We have a family history.
family history, correct. And consider adding one of these quick performance mobility things if you don't want to do a more formalized test, like a gait speed or a timed up and go. You could do a quicker performance screen. If you guys want to have a wealth of resources, you can grab a quick screenshot here. 1959 was my old citation. 2025 is my new citation. Wow. So this information, these red flags, these elephants have been living in our clinics for decades. Let's see if we can be a little more proactive and preemptive. All right, questions?